Great. So this is Debbie Zeldo. I'm the Executive Director of the National Bone Health Alliance, and just wanted to go over some housekeeping items before I turn it over to Tom Olenginski, who will be our moderator today. So please mute your microphone when you're not speaking. The other key thing for us is, I'll just mention to use the chat function. If you have a question you want to ask and don't want to forget it, or you can also just speak after the didactic. And then we do ask that people put in their name, location, and email so that we can make sure to get you the CME for today's session. One of the pieces I wanted to go over is patient privacy. Here are the common HIPAA, you can go ahead. Common HIPAA identified slip-ups and easy ways to protect patient privacy. I'm not going to read these again, but if you please take a look at your screen and remember that patient privacy is number one, and we will make sure that we cover these different areas. Great. Right now it's my pleasure to introduce Tom Olenginski, who will be our moderator today. Tom?
Thank you, Debbie, and I'd like to welcome everyone today to FLS ECHO. We're privileged to have Karen Vujevic from the University of Pittsburgh. I know a little bit about Karen from talking to her over the last 5 or so minutes. She's been at UPMC for the last 24 years, and the last 14 of those years have been directly involved in osteoporosis care. She's a board certified family nurse practitioner and has been involved in University of Pittsburgh's FLS and is going to talk to us about that. After Karen's didactic, we will be open for questions about Karen's presentation, Karen's program, questions involving other types of FLS programs, and then I know we at least have one case to present, and then we'll go from there. So having said that, I'll ask Karen to present her didactic. Thank you, Karen.
Thank you much. Okay, let me just try. Okay, it's saying I can't share the screen.
Give me 1 second. Okay, go ahead.
Okay, let's try that now. Okay. So I have nothing to disclose. My objectives in putting together this, brief presentation was really just the challenges faced and the solutions that we identified here at our institution. And understand that the FLS needs to be adapted for the challenges that you are going to face at your particular institution. It will be different based upon where you're located, the culture of that organization. So mostly you want to just be patient with yourself, realize you will have to adapt. Also, my third objective is just to discuss how I work to try and build an awareness of the FLS within the hospital system itself. So challenges of a new FLS. We're not quite new anymore. We're actually about a little more than 4 years old now. A bit of our history. Prior to becoming involved in a nationwide project, which I'll tell you about in a second, we really only research here in our office. So we've done a whole slew of research looking at anywhere from nursing home patients to cancer patients, different medications, how they work, et cetera, et cetera. So we had a very strong background in osteoporosis, but not as a fracture liaison or a clinical type perspective. So that was a bit of a challenge for us. We were one of 3 sites that were selected back in, I guess it was the end of 2013, 2014, to pilot a online cloud-based tool to follow patients in an FLS system within an open community. Our particular facility, UPMC, is a tertiary trauma center, so we draw from all the surrounding states, from Maryland, Ohio, West Virginia. We've got some from New York. It just really depends, and we'll see all sorts of insurances. So if they happen to have the insurance that our institution, also has available, it makes it very easy to track and follow up. If they do not, that makes it part of the challenge that we have found. The process that I utilize currently and this is just, I'll do a brief overview and then get into it a little bit more after the fact, is that I have patients identified either through a consult with the various services or from a review of inpatient records. I see the patients once I've received that consult one way or the other. Initially, I just go out, introduce myself so that they sort of have a face to, they can put to a name and begin to introduce the concept of the fracture liaison service. I order any labs that may not have been drawn yet or that I deem appropriate just to rule out any secondary causes of osteoporosis. And then I'll follow up of the abnormals while they're still in, and then I follow up with them as outpatient. We have a DEXA scanner in our office, so it makes it very convenient. We're also located one floor above the orthopedic clinic, so we can typically do like a one-stop shop. They'll see ortho and then finish that appointment, come up and see me. I can get the bone density, review that with them, the labs, etc., and then start them on treatment as necessary. Once that's all accomplished, then I send out the DEXA reports and the PCP letters, identifying everything that we have done, what we had discussed. If the patients were not interested in getting started on the medication with me right now, but wanted to pursue with their PCP, then I would discuss at that point in the letter what we had discussed, what we suggested as probably the best treatment options for that patient based upon their other comorbidities. And then I do a PRN follow-up on some patients. I am a one-woman show, so I don't have the resources available to call every single patient, and that is sometimes a bit of a frustration, but it's what we have, and that's what we're working with at the moment. So one of the first challenges that we faced when we were initially piloting that program four plus some years ago was with our orthopedic department. It really was just sort of a bad timing scenario. They had just started using electronic health records, specifically Epic, and they see anywhere upwards of 70+ patients a day in their clinic. So there was concern that we would be impeding the flow of their patients if we saw our patients before their appointment. So we absolutely could only see their patients after their orthopedic appointment. And the orthopedic appointment, could run anywhere from a half hour to 4 hours, literally, depending on how busy they were. So it sort of makes it a bit of a logistic nightmare for me because I have to have a DEXA tech available and then make sure my schedule's somewhat clear. They also were very reluctant to have their residents that were seeing patients in-house ordering any FLS type labs, for example, a 25-hydroxy. They didn't have time to follow up with those labs, they felt. So that was just something we had to learn to kind of work with. Interestingly, what I found since that time is that different hospitals within our own health system, there's different orthopedic cultures within each of the hospitals themselves. Some are just much more amenable to the whole FLS concept. They're just all over it. Others kind of see us as not a burden, but that they'll help us as they can. So just different. So what we came up with to try and deal with that orthopedic issue was I was not getting any referrals from them. They just were not going to do it, and that's essentially what was said. But what they did do was give me proxy access to all the co-managed.
Calculated. Please proceed to the.
gave me proxy access to the co-managed inpatients. So co-managed meaning that medicine and ortho were seeing them both. So I would review those patients each day to see who would be appropriate for, the fracture liaison service, and make my rounds after that. We've worked very hard over these last 4 years to really prove ourselves to the ortho team that we weren't going to impede their flow. We definitely only scheduled patients after their orthopedic visits, especially for the initial visit, because some of what I have found over the years is that my best chance of success of actually getting these patients in to see me is if I see them either at their 2-week follow-up visit or their 6-week follow-up visit. So for the very first visit, I do not schedule beforehand because I don't know what their ambulation limits are. And so it's just easier for me to see them after that visit. But once I know that they are more ambulatory or they're on a stretcher and we can just roll them over, whatever, I will try to schedule them ahead of time to make my life a little bit easier to deal with, as well as our poor Dex attack. And we absolutely ensure they are downstairs in the orthopedic department at least 15 minutes before their scheduled appointment. We met with the chief of orthotrauma like 2 to 3 times, actually 3 times, twice in person and once via teleconference to, explain what it is we do and how we would be a benefit. And then they actually began asking for some data regarding our FLS numbers because, we were seeing quite a few patients, and, it was just interesting that over the years that has begun to slowly warm to our department. And now we're actually starting to get referrals from the orthopedic department themselves, which you just wouldn't understand is just a really big deal. So we're quite happy from that perspective. Challenges of the new FLS from the inpatient perspective. So again, we were completely research focused. We did nothing in the hospitals themselves other than consenting patients for research studies. So we were completely unaware of electronic health record systems. It was just all completely foreign to us. So we found then that there were 2 different electronic health records in our institution, one for inpatients, one for outpatients. There are 4 to 5 providers that were listed for each patient because everybody is consulted, from the geriatricians to the rheumatologists, endocrinologists, orthopedic trauma, spine ortho, et cetera, et cetera. So, who takes first call on that? Who would I need to call to get, permission to go see these patients? There was a difference between the chief of trauma and the ortho chief of trauma. In my world, I would have thought that was one and the same. It is not. How do we get our services on the provider's minds for the consults? How do we get our name out there? And how can we make it easier for them to consult us? So some of the solutions we found were scheduled classes to learn the 2 systems that we use, which are Epic and Cerner. And still learning, still attending. I actually, thankfully, these systems have tutorials even now online. And I have a whole binder I have put together of all the various problems I've encountered in each of those systems. And they'll talk you through step by step how to do it. So it's a pretty full little binder because I have definitely made some mistakes along the way, but have found ways to correct them. And then also just to kind of, again, get our name out there, explain what it is we do. We've scheduled multiple meetings with various departments and department chiefs over time, just to introduce ourselves and get their blessing. And that included geriatrics, neurosurgery, trauma, orthotrauma, internal medicine, the hospitalists, and definitely the APPs, who have ended up being, one of my best resources. We had to reassure all those various departments because everybody is so specialized anymore. It was, I guess they just didn't want to add a vitamin D to their repertoire. I mean, it was just well, how is that, a deficiency treated? And, we're dealing with so many other issues. We just don't want to take that on. So reassured them that, I would follow up on the labs that I ordered, and that seemed to really put their minds at ease. And as I said earlier, I did have to work to find out who's like in the pecking order, or like who's my best chance of getting a referral to see these patients. And definitely the APPs were the most accessible. The other thing I did to get our name out there, because, and I'm still running into it, it's like, what do you do exactly? Is I don't use the term FLS except when I'm communicating within my own department, because people just don't know that. So I write it out, fracture liaison service, on everything, on my emails, on my orders, everything. It is always written out, and it just has helped to get that name out there. Other things I've done is written little articles for the UPMC newspapers that we have for the various departments. I've sent out a few of those, again, explaining our services, how to contact us, what we do, etc. So it's laborious because, as I said, I'm a one-woman operation, but it's slowly beginning to make some headway. We also only have one dedicated ortho floor across 2 hospitals that are connected by a bridge. So orthopedic patients are scattered throughout the entire hospital system. So I will see patients anywhere from that ortho unit to neuro ICUs, emergency room overflow departments, wherever they, will send me the consult. I do have to see them. But because of that, there wasn't like one unit or case manager or whatever that I could work with. I just began, introducing myself to everybody that looked my way. I was passing out my business cards constantly. And so I would just, yeah, I'm with this service. This is what we do. Oh, okay. And continue to, do that. And I still do that even as of today. Also, I was invited to participate in a committee that was UPMC hospitals wide that was looking at guidelines for geriatric hip fractures. We had already had a fracture pathway that was being developed, but with all the changes at CMS, we were trying to put this together to use as one of our particular areas of focus, and was very impressed and I guess pleased that so many of the other hospitals were just really interested in what we were doing, and excited about what we had accomplished here, and could we get that started there. So it was just reassuring and reaffirming for me. The other thing we did to, again, make it as easy as possible for the hospitalists and the APPs to consult us was worked with the clinical operational informatics group at UPMC to get FLS listed as a one-click consult. Let me just say, it took forever to even find out this group existed. Again, we were coming from a research, very, focused group. And you'd hear this terminology, oh, just talk to your IT department. I mean, we must have 200 IT departments at UPMC, and truly did not know even where to begin. So it was more just talking to one person versus another person versus, another one, that finally led us to this clinical operations informatics, and they were the ones that were able to help us get the consult set up. Then as outpatients, some of the challenges that I faced, getting patients to call and schedule with me. What I have found is I actually track these patients down. I have a spreadsheet on Excel, just a very simple spreadsheet that tells me when they were discharged and where they were discharged, whether it was rehab or home. And then I follow to see when they're scheduled to see orthopedics. When I find out they are scheduled, that's when I begin the process of trying to call them. If they're in rehab, I call the rehab transport coordinator person there and get them scheduled. And then I also follow up with one of the family members, if possible, to explain what it is we're doing, and can one of them come with the patient. If they are at home, then I do the same thing there. And as I said, try to coordinate it with their orthopedic appointment to minimize how many times patients have to come into Oakland. I'm not sure where you're all from, but for whatever reason, Oakland just has well, actually, I know why. Oakland has a bad name when it comes to traffic. Every road is a one-way road, and you can't get there from here. So patients just abhor coming to Oakland. So if I can limit how many times they need to come actually see me, and if I can coordinate that with a orthopedic visit, it seems to go over best. The other challenge I faced is convincing patients that their fracture is because of the osteoporosis and not because it was an accident. And I'm sure you all face that as well. Drives me just to distraction. You know, if I hadn't, you know, slipped on the ice or put my foot in the gopher hole or, you know, tripped in the grocery store, whatever, it's always just an accident. And what I found is that the term fracture in their own mind is, again, an accident. If only I hadn't done the gopher hole, slipped in the water, et cetera, et cetera. The other challenge that I hear all the time are, what are the side effects? I don't want to take any more medicine. I don't want my teeth to fall out. So what I have had to do over time to try and encourage the patients to call and schedule with me is on my inpatient note, I have put in italics and bold, please have the patient and his or her caregiver contact me to schedule. And that is actually directly. And so that has actually started to show some improvement. I just had 2 patients' daughters call me today. So it is starting to have a little bit of a, help, and that decreases how much work then I have to do tracking these patients down. I've also found that over the years, I've had to change my pattern. I don't use the word fracture as much anymore because, again, fracture, for whatever reason, just seems to presuppose it was an accident. And if I hadn't done this, I wouldn't have broke. So now I use the word pain. For example, you don't want to go through all this pain and the rehab again, right? And somehow in their mind, this just seems to have more of an impact for getting them to agree, even though they're, you know, they broke their hip, their DEXA scan is horrendous. Saying it's just a fracture does not seem to work. If I can show that they don't want to go through the pain again and the rehab, they're just much more amenable to the medication route at that point. I absolutely try to make sure that I have a family member there with the patients because, again, I have put together a packet, which I'll tell you about in a second, but it's a lot of information. I'm reviewing a bone density with them. I'm reviewing medication options with them and possible side effects, et cetera. It's just a lot. And if I have a family member there, it's just easier for the 2 of them together to kind of ask the right questions and to help to remember. And I also use it as a teaching moment because most of these patients, children that are bringing them in or siblings that are bringing them in or spouses that are bringing them in can use this information as well. I mean, they're completely unaware of how, you know, you evaluate how much calcium is in your diet or why calcium is even important or, you know, those sorts of things. So it's been helpful. I did just put together an FLS packet myself of what I felt was important, and that has changed also over time based upon newer information coming out, but also what I found the patients' questions were over and over again. So this way they had something to reinforce what we discussed once they got home. And it just, I mean, it's the basic information from like the NOF, you know, on medications, calcium and vitamin D, exercises, etc. I also put together a binder of actual, and I keep this in my conference room, but it's a binder of actual risk of fractures in osteoporosis patients versus those with ONJ and AFS. And you probably have seen these in a variety of formats, but it's like the, you know, 1,000 smiley faces on one page, that sort of thing, and, you know, how many fractures, you know, in a woman would be darkened, that sort of thing. But it helps to just for them to see it in concrete terms. The other thing I use to try and equate this real risk of fracture with numbers is we have a couple of like concert halls in Pittsburgh, like the Benedum or the Heinz Hall. And most patients that I see here are familiar with that. So I'll explain that, yeah, you know, this first floor, you know, we'll see 1,000 patients, and how, you know, 1/2 of those 1,000 patients, you know, over the age of 50 will fracture, and et cetera. And that just helps for them to kind of put that into perspective in their own mind. The other thing I found was, you know, the other side effects. That was the biggie. So I went on the websites for Tylenol and Bayer aspirin and downloaded from their websites their list of potential side effects. And what I do is I cover up the particular drug when I let them see all the horrendous potential side effects for Tylenol. And they are pretty much aghast when they're looking at it, but then I move my hand back and then they see it's Tylenol, and it's kind of like, oh, okay. because unfortunately Aunt Sally's cousin, had told somebody that Fosamax would cause her teeth to fall out, and therefore it was gospel. So this way, if I'm actually showing them kind of reality, it seems to have a bit better impact. So the challenge is still to be conquered at our particular institution. Is I am a one-woman/person show. When I'm off on vacation or off on the weekends, the staff will just take a name and number, and they tell the nursing department that I will follow up with them the following week. It is definitely more of a challenge, I find, if I don't see them first in the hospital, to almost cold call them, explain what we do, that sort of thing. So getting additional support for coverage would be, that's my goal and definitely what I'm working towards. I'm unable to take on any emergency department fractures that are not hospitalized, again, just because it is just me. I should back up just to say that I can't speak at all to any billing issues as far as services provided, other than for the bone density test or for the lab work that I order. And the reason is that I actually work for the University of Pittsburgh, and but I am seen as a consultant for UPMC, and there is some sort of bridge that I don't fully understand, but even though I'm authorized to bill, we can't bill if I work for Pitt. And since I am so close to my retirement, I'm not going to switch over just so that I can begin billing. So the way that I am paid, though, is through UPMC, and they are actually supporting the service itself. So because of that, there is no charge to the patients for me to see them in the hospital or for me to see them after the fact. We do charge for the bone density, of course, as well as the lab work. So, but because of that, and because we don't bill, we are in the process of trying to, get permission to hire an additional APP that would actually be a UPMC employee, so that we could begin to do that billing process, and then that person could eventually take over for me. The other issue, a challenge is still to be conquered, is how we are doing the scheduling of follow-up visits that we've pretty much already discussed. So really the take-home messages, this is just what I have found to work for me here. This, has just been an ongoing, work in progress, and it still is. It is by far, far from perfect, but so far it's working, and I am having some impact, I'd like to believe. With that, I will go ahead and sign off and take any questions if you have any for me.
Karen, thank you very much. This is Tom Olenjinsky. I'm just going to summarize what I heard because it's phenomenal, and I think people in FLS care can hear and identify with your startup and your struggles and your adaptation. So there's no one-size-fits-all FLS. There's different ways to case find, different flows, logistics. Your idea of trying to match follow-up with orthopedic follow-up because of your location is very similar to ours, and we've not solved that. You're clearly attentive to the concerns of the stakeholders. In my opinion, they should be they should all be more attentive to our concerns, because we're really on the same team and we just have kind of a different perspective. You talked about the importance of communication, the role of branding your program, the difficulties in care coordination post-fracture, and really, importantly, the importance of advanced practice providers in FLS care. So I thank you and invite others to ask some questions.
Can you speak at all to any interaction you have with primary care doctors in your FLS when the patient is released from the hospital?
Oh, yeah, that's actually a good point. That's an area I think that just osteoporosis stakeholders in general really need to assess. I think osteoporosis is one of those disease processes that you can just push behind. don't want to say that I directly have received pushback, but I have had patients say that, no, my doctor does not want me to get on this medication because the medication is much worse than the hip fracture. And, you know, of course, I want to pull my hair out, but I also don't want to do anything that might disrupt that relationship, because that is so important to have a patient, primary care provider, trust, you know, relationship built. So I just reinforce again, you know, the realities. You know, I offer again, start them myself if they're interested, but if the PCP does not see it as a concern, then unfortunately patients do not get treatment. So I send everything to these PCPs. I put down all their risks. I put down all their previous fractures, their DEXA scan results, FRAC scores if it's appropriate, you know, how the medications could decrease this risk of fracture by this percent. But if it's not a priority in the PCP's mind, that unfortunately it does not get taken care of. And that's why I just think that the education that we've been talking about at some of the national meetings of primary care docs on just how serious a hip fracture or, you know, any fragility fracture could potentially be might help. In their defense, I mean, I did do primary care, as I said, for 6 years. And, you know, obviously it's the noisiest, loudest disease processes that are going to percolate to the top and get my attention. So if somebody's coming in because they can't breathe, or they've got chest pain, or I think my arm's going numb, etc., you know, it doesn't matter that they broke their hip. I mean, I'm, you know, 6 months ago or whatever. What I'm thinking now is this a PE, an MI, etc.? So, you know, or their diabetes is out of control, or is it an abusive situation? I mean, all those things just tend to become more important. So I think if we can somehow find a way to communicate to the PCPs that this is pretty important too, that helps. And I had referenced that I changed my pattern over time. And one of the things I do say to patients is that they need, if they don't want to schedule with or start treatment with me, is that they need to schedule an appointment with their primary care doctor specifically to discuss their bone health. And I emphasize that over and over again, so that, you know, even though they might be going in for other issues, that would be it. Because I've had so many doctors' offices say, oh, I've never received the DEXA. No, I never received the letter. And again, something simple. I would put my letter on top of the DEXA report. Somehow the DEXA report would get stapled to the letter, and it would end up in the communication portion of this patient's folder, and the doctor never saw the DEXA scan. So I found now that I'll actually put the DEXA report on top of the letter, and they seem to be able to see it easier. So, you know, it goes through many layers once it gets to the PCP's office. So I'm not sure if that completely answered your question, but that's sort of what I've done.
Can you talk a little bit about, you know, you mentioned the IT piece and how key that was, but how it really was a search. I think you said there were over 100 IT departments.
Oh, I'm guesstimating, but I would say, yeah.
Can you give any clues or other ways for people to find the right department more quickly? Because I really love the idea that you shared about having FLS really put in almost as a button for people to use.
Right. How we actually ended up coming to this was we were at a different meeting altogether, not even related to osteoporosis. And somebody mentioned something to Susan, and I am very fortunate to work at a department. Susan Greenspan is our medical director. And I was at this meeting with her, and when we heard these people talking, it was kind of like, oh, wait, what about, so, you know, we discussed it with them after the fact, and they said, well, who you need to contact is this. So that was really almost by accident. What I also had found since that time was, even though we were doing research, we would do a lot of our research at one time on one of the nursing units over in one of the hospitals. And they actually functioned as a nursing unit. So I used those people as resource people to like, you know, if I wanted to get this done, who would I call? And then they would in turn give me a name. And of course, that first name was never the right person, but I would explain what I needed, and they would then defer me to somebody else. And then, sometimes it, could take a couple of calls, but whatever connection you have to begin with is probably the best bet. We have, an IT department that manages just the medical component at Pitt. And then there's an IT department that manages the medical component at UPMC, and they don't interface at all. So, it's a pretty overwhelming process. But I think if you could just start with something small, it may take a few phone calls, but you might be able to, find out who that particular person would be to get it started. And once we did, these staff and providers were phenomenal at getting us up and running. Any other questions?
This is a 26-year-old female that I was referred to me because she had a 5th metatarsal fracture in January of 2018, and it is not healing at all. She previously had, she was rollerblading when she was 21 years old, so about 5 years ago, and she was just about at a complete stop and fell and had a pretty nasty both bone forearm fracture, had surgery, didn't heal. They had to use a bone stimulator. So she's just had some bone problems her whole life. She told me that she has a milk allergy and has for her whole life. So obviously she doesn't do any dairy. She does a lot of fruit and vegetables, meat, no history of any eating disorders. Let's see here. Maternal grandmother has osteoporosis. She has a history of migraines, so she's on different medications for those. She was in a motor vehicle accident about a year ago and has neck pain and shoulder pain, so she takes tramadol and meloxicam for that. She has had 2 benign tumors removed out of her breasts within the last 3 to 5 years. My last visit with her, she told me that at some point in time, she was, they did blood work for lupus, and part of it was positive and part of it was negative, and that's all that happened. I don't have that records yet. She's trying to get all of that together. She's, you can see her list of medications. Like I said, the tramadol, the meloxicams. She has chronic UTIs, so she's on the macrobid quite a bit. She's had the Mirena IUD for the last 4 years. She had a daughter who was 4. If you want to go to the next page, perfect. You can see her height and weight. She does work out. She runs up until this injury. Her DEXA scores, you can see her Z scores there. Sorry for my handwriting. As far as her labs go, everything was normal except her BUN creatinine ratio was low at 7.9. Her vitamin D was 27. 24-hour urine for calcium was low at 37.8. And then her estradiol, FSH, all that stuff came back good. So her onset of her periods was at 12 years old. She's never been regular. She would go 6 months without a cycle. She was put on many birth control pills, would get a period, and then they would last 1 or 2 days and then be gone for, again, 6 months. She got pregnant while taking the birth control pills about 4 years ago, breastfed her daughter for 1 year, and has had the IUD for the last 4 years. She's getting married in September and wants to have another child, and obviously nurse that child as well. So she gets Botox and has had epidural injections, I guess Botox for her migraines and epidural injections in her neck for that neck pain. Any other things, a celiac panel was normal as well. Any other things that you guys would think of doing or checking or testing?
So Amanda, I'll try to summarize this
Yep.
for you. So in summary, we have a 26-year-old woman who at age 21 had a wrist fracture after some incident, has a difficult healing left fifth metatarsal fracture. She has a background history of neck and shoulder pain, chronic UTIs, headaches, and seems, in my view, from afar, maybe to have a generalized pain syndrome or, for lack of anything better, what I like to call a central sensitization syndrome. It seems to me like her pain, just based on her age, is much more likely myofascial than clearly structural. And again, the Botox might affect that. So her DEXA really does not show terribly off Z-score. So at her age, a Z-score of minus 1.3 at the spine and minus 0.8 at the hip in someone who's not yet attained peak bone strength is not out of, it doesn't necessarily raise any red flags. She's a little, not quite vitamin D replete, and I think her low 24-hour urine calcium based on her milk allergy and her diet might suggest that she's really calcium deficient as far as maintaining her basic calcium needs. And otherwise, there's nothing that really stands out on her metabolic evaluation. So does anybody else have any input in regard to this case?
You don't think bone turnover markers are important, correct, at this point? I mean, because, and again, this is just a different, I just don't know what to tell her, that everything's good.
So I'll just give you my take. So what I sometimes have to remind myself is I would say that while some people think I'm a bonehead, a lot of people do, I put myself a category below the people who just deal with bone constantly and have a good idea of unusual bone diseases. My gut here is, apart from the healing issue, which may need to be addressed orthopedically in a different way, I'm not sure that there's a primary or true secondary bone problem here. Since I know that Dudley is on the line, and I met him last week, Dudley, do you have anything from your standpoint that you could add here? And of course, if Dudley is not on the phone now, so I mean, if I'm seeing this patient, I guess what I'm going to try to communicate to ortho is, do we need to readdress her? I mean, what do we do about the non-healing metatarsal fracture? I think that's probably a little bit of a different issue. So in general, I think we would say that fractures of the face, skull, hands, and feet are a bit different. And my general sense here is, if you told me, from what I hear, I think I have a low suspicion that this woman has lupus. If you told me she had fibromyalgia, it would fit. I think she does. So I think some of her, she's relatively active from what you say, Amanda.
Yeah.
But does she need to be? I mean, how's the stress fracture been taken care of?
She was put in a cam boot, non-weight bearing. I mean, and they've kind of progressed it, but her last X-ray was March 27th, and literally there is no, callus formation. So, and I think that they are going to get her into like our podiatry group because she hasn't seen them, and it likely will need to be surgically, repaired. But
yeah, I mean, I guess the only thing that concerns me would be the sense that maybe she's not getting enough calcium intake.
Okay.
my general sense in the general context of the use of markers, in general, if a fracture is relatively recent, there's going to be potential interference with some of the markers of bone turnover. But quite honestly, for most of the fractures that we see, for a number of other reasons, we tend not to use markers very much.
Fair enough.
In part, do them on site, and so that's frustrating. But again, I'm at least reassured by I mean, you know, if her Z-scores were minus 2.5 or minus 3, then you'd really be obliged to go more further with some unusual, you know, secondary bone loss factor.
Right. Okay. Well, thank you very much.
So, Amanda, thank you for presenting that.